Hello, and welcome to the global launch of the Lancet Gastroenterology and Hepatology's Commission on Viral Hepatitis. This is an update of our previous commission published in 2019 to assess progress towards WHO's elimination targets for elimination of viral hepatitis by 2030. Before we launch into the webinar itself, there are a few items of housekeeping to address. The questions section of the webinar platform is open throughout the webinar. Please just submit your questions through the Ask a Question box in your dashboard. You will also see a box with related resources, which include links to the Commission and other collateral that we've published today linked to the Commission. You can also adjust or minimize any of these boxes on the webinar dashboard to suit however you want to look at the information. We will be sending you an on-demand version of the webinar once the event has concluded, and we ask that you please complete a 30-second feedback survey at the end of the webinar to help us to improve our future webinar offerings. So it's time to meet our star-studded panel of guests for this webinar launch. We'll be hearing from Graham Cook, lead of the Commission, who is Professor of Infectious Diseases at Imperial College London and an NHS consultant. We'll also be hearing from Diana Alcantara-Payawal, who's Professor and Chair of the Department of Internal Medicine at Fatima University Medical Center in the Philippines. We'll also be joined by Haile Michael Desalegn, who's Professor of Medicine at St. Paul's Hospital Millennium Medical College in Ethiopia. We're also joined by Funmi Lesi from WHO's viral hepatitis team. And for the question and answer session, we'll be joined by Lindsay Hebert, the Associate Director of the Coalition for Global Hepatitis Elimination. Our agenda today will feature Graham giving a top-level overview of the updated Commission before Diana launches into an overview of experience from the Asia-Pacific region. Haile Michael will be giving us an update on elimination efforts in sub-Saharan Africa before Funmi takes us through a global perspective of these aspects. We'll then have time for a questions and answers session with all of the panelists, including Lindsay, before we wrap up. So without further ado, I'd like to hand over to Professor Graham Cook to take us through the new Commission.
Thank you, Rob, and thank you to everyone. I'm just trying to see the slides, so I'll just see if I can do that before I start. If not, I'll just go down the side. But thank you very much for the opportunity to talk. And sorry, Sophie, but I can see the sidebar, but I've got a big white screen in front of me. So if we could just spend a moment to fix that, that would be helpful. What I will do is pull up my own version of the slides and hope that I can get them to match. Great. So I'm assuming you can see a slide that says the aims of the update. And if you can't, someone please let me know. So the aim of this really was to complement the work of the global agencies and not to overlap, and really to try and assess the progress we've made against the previous recommendations. And within that, we really wanted to bring a greater focus to what we're calling the H20. So these are the 20 most heavily burdened countries with viral hepatitis in the world, accounting for about 80% of the global burden of disease. But really importantly, what we wanted to do was try and support the development of a broader elimination community across these countries, trying to bring in as many stakeholders as we can in that process. And I'll talk a little bit more about that. And then having done that, to try and identify sort of more common emerging themes that weren't perhaps emphasized within that first Commission piece that we did. On the next slide, I hope you can see the countries in red, which represent the 20 most heavily burdened countries, and the people within the Commission who've helped us to write and update about each of these countries, about the challenges they have, the opportunities, some of the successes in particular that they can share. And I'm very grateful for everybody who's contributed to this. It was an underfunded piece of work, and so it's really been a level of commitment that we're very grateful for. I think it's also really important to emphasize some of the other groups who've been involved. So the Coalition for Global Hepatitis Elimination is very important, and I'll talk a bit more about that, and Lindsay will join us for the discussion. IS Global, in particular, Jeff Lazarus and Adam Paliu, who led some of the work on the Elimination Index. The Institute of Health Metrics and Evaluation with Hannah Han and May Dirac, who worked on the global burden of disease data. I think the journal itself deserves acknowledging. Rob and the team, I think the journal's been really helpful in trying to push together the policy agenda, and you'll see a range of papers that have just come out this week from the journal across a range of things, which I think is an illustration of that. And one of those actually is from the Kirby Institute group, led by Alison Marshall with Jason Grebley, and both of them and Evan were really helpful in putting this together. And finally, some of my team at Imperial, in particular Barney Flower, who I think did a lot more heavy lifting on this than either of us thought it was going to be needed a year ago. So assuming that some of you present aren't fully familiar with what we're talking about, then really when we're talking about viral hepatitis, we're talking about 5 viruses. But for the purposes of today, really we're talking about 2, so hepatitis B and hepatitis C. And what this figure at the top shows very crudely is really the size of the circles of the numbers of deaths that are due to hepatitis B in different parts of the world. And you can immediately see in yellow there hepatitis B, I hope you can see, and in red hepatitis C. And the burden of disease, particularly in Southeast Asia and Asia, but throughout the world with a different balance between different settings. And the numbers of deaths from viral hepatitis are very high, and they're comparable to other diseases like HIV and tuberculosis. But differently distributed in the sense that they're similarly distributed between higher and lower income settings. And there are pros and cons to that we might come back to in discussion. But on the next slide, it's really just to show the targets for elimination that were set out with the WHO some years ago now, back in 2016, that have been a really useful framing for where we want to try and get to by 2030, with a reduction in new infections by 90% and a reduction in mortality due to viral hepatitis by 65%. And as we'll hear, there's very mixed progress towards those targets, and very few countries actually on track, but I think they still represent a really important ambition for the community as a whole. So on the next slide, I said back in 2019, when we put this first piece of work out, then we brought together a very broad range of experts from across the world and discussed in detail a range of issues that will be needed to achieve these elimination goals. And we made some key recommendations that were targeted both for national and international stakeholders separately. And on the next slide, I'll start to go through this a bit, and I'll probably have to ask you to click. And it's going to struggle to read it, but I think that this is to illustrate some of the issues with international priority actions that we put together. So we wanted this extra focus on high burden countries and support for policymakers in those countries. And I think one of the initiatives that followed the first commission was the launch of the Coalition for Global Hepatitis Elimination that I'll come on to. If we click again, then amongst the recommendations for prevention, one of the key things is around access to birth dose hepatitis B vaccine. And I think we've seen an interesting period where Gavi, the international funding agency, proposed and supported the introduction of funding for birth dose vaccine, particularly in low-income countries in Africa. And then that was put on hold during the pandemic, but finally re-announced recently. So I think that's a real sign of progress that's coming. We emphasized the need for a hepatitis C vaccine, and there's been much more modest progress in that than we might want to talk about later. Throughout the last commission, we emphasized the need for simplified models of care and the need for operational research in simplified models of care. And that's seen real progress, I think, particularly in hepatitis C. Simplified pathways are very clearly on the agenda. Hepatitis C self-testing has really got greater prominence. But as we'll discuss, for hepatitis B, that's still some work to do, and I think there's still more needed there. Part of simplified models of care requires diagnostics, and I think we've seen progress with new rapid diagnostics approved, a new finger prick viral load approved, and others too. So there is progress in that direction, but still access and affordability to diagnostics is a challenge throughout many parts of the world. In terms of access to treatment, I think all the key hepatitis drugs for hepatitis B and hepatitis C at least are now, at least in theory, available through voluntary licensing. And I think that one of the papers I was referring to from the Kirby group has looked at that in more detail recently. And I think there's a really useful report that's been produced by the Clinton Foundation on monitoring pricing, which I think is helping understand progress there. And finally, we recommended the creation of an index to allow measurement of progress towards elimination. And I'll talk a little bit more about that shortly. And within that, we wanted this greater focus on the most heavily burdened countries, the H20, for whom sometimes the focus is elsewhere and they can be neglected. On the next slide, I won't go through all this in so much detail, but these were really aiming more towards national priority actions. And we wanted to be able to see fully funded elimination programs in countries by 2020. Now, many countries have new plans, but not all fully funded, and we may talk about that a little bit more later. Within prevention, we still have challenges in terms of access to harm reduction and the policies required to do that, and I think that still needs some more work in many settings. In terms of diagnostics, we recommended that there needed to be greater focus integrating diagnostics for hepatitis into the wider healthcare system. And we may see some legacy on COVID in this in some settings where investment in diagnostic services does have the potential to offer to support other areas of testing. But really, there's still more work required there too. In terms of access to treatment at a national level, there's definitely more work needed to try and take advantage of some of these prices that can be available and make sure that national programs are making the most of their resources. And finally, we recognize the need for many of these countries to develop in-country capacity to both manage and advocate for viral hepatitis when there was a major problem that was being unaddressed. So on the next slide, just to talk a little bit more about the Coalition for Global Hepatitis Elimination. As I say, this was a recommendation from the previous commission, recognizing the many dimensions of what was required to achieve elimination of viral hepatitis, and that some countries have made really substantial progress, which remains the case, and some of those are in some of the poorer parts of the world. And I guess the best example, which we'll hear more about, I think, later, is Egypt, where there's been substantial progress. But there are clearly most programs in the world, wherever they are operating with very constrained resources. And there was a real need for a community of practice, for strategic data and technical support that this was set up to address. And aligned to this update, then the Coalition has been developing what they're calling national hepatitis elimination profiles. And these are available online and regularly updated with key strategic data for each of these countries. And this is really helpful, I think, in country for advocating, for helping with the strategic data, for planning services and so forth. And so I think this is a really helpful resource. We can't really talk about the last 5 years without talking about COVID. I won't dwell on it too long, but clearly there's been major disruption to services and programs. There's been diversion of resources, and there's been pause of major initiatives. And I think that Gavi policy on hepatitis B vaccination is a good example of that. We know that 250,000 children each year are getting infected at birth, and most of those can be prevented with hepatitis B birth dose vaccine, preventing deaths in the future. And for each year that the implementation is delayed, then that's another year of more infections happening. So it's great that it's back on track, but clearly there has been a diversion from COVID-19. But I think we should be looking for the positives that we can use for viral hepatitis from COVID-19. And I think there are some. I mean, that's not many. But there is a much better understanding of infectious diseases in policy making and in the public, which I think is helpful. And there has been some investment in some areas around infrastructure for surveillance and testing, which we should be able to take advantage of. Self-testing in particular, I think, has become much more acceptable. We've seen it adopted more enthusiastically in HIV in particular, and I think more we can do in hepatitis. And then we've seen the decentralization of models of care. My own clinic in London went from fully face-to-face to fully online within a couple of weeks. And I think the challenge for us all is to maintain that momentum and use these models to ensure that we can decentralize care as soon as possible. And then finally, we have the acceleration of new technologies. And I think the best example here clearly is mRNA vaccines, which do offer up a new tool that we might have in the armory in terms of developing future vaccines, in particular for hepatitis C. If we're looking at these 20 countries that we've talked about, then we can't ignore the impact of conflict. I think 4 of the countries have had major conflict in the last 5 years, Ukraine and Russia, Ethiopia and Myanmar, and we'll hear a little bit more about Ethiopia in particular later. But clearly in that context, trying to make progress on an issue like viral hepatitis is even harder than it would be normally. It's mindful to remember that. So where are we in 2024? Well, I think the key thing is that for me, viral hepatitis remains an anomaly in global policy. This is a major cause of death, a major cause of disease burden, with tools available and increasingly affordable to tackle it, but without that global funding mechanism that we see for HIV and TB in particular that can address that. And so we do have to have this sort of conversation about to what extent we should try more to do that, and to what extent we should be working at the national level to make sure that as much is being done as possible. And there has been great progress, but we have to be realistic, and the great majority of infections, both for hepatitis B and hepatitis C, are still undiagnosed. And to take an example then for hepatitis C, then we think probably about 14 countries are on track for the 2030 targets, so not many, and only another 12 by 2050. And if we look at the estimates of how many people have received courses of generic antivirals, DAAs, then we think it's somewhere around 1.5 million, just under, which is a big number, and it's great progress, but there's still only a fraction of the people who need it to be treated globally. And we are starting to see some demand waning in some settings post-COVID, and hasn't picked up again. So in terms of the Commission update, then if I go to the slide for burden of disease, I think that we've looked again with the team from IHME and identified these 20 countries. And I think some of this is unsurprising given the size of populations, then the burden of disease is very high. But it's important to recognize that there are quite diverse countries here. There are some very rich countries and some very poor countries. The balance of hepatitis B and hepatitis C is very different. The access to treatment is very different. And so I think trying to think sensibly about this as a whole is quite difficult for me, at least. And I think looking at that more national level is important. And that's what we'll hear more from Diana and Hailey Michael later about. One of the other challenges that is clear to us all, and we might want to talk about a bit more, is the challenge of consistent data. And one of the things we were asked to do as part of this was trying to put together what I think someone called the table of truth. Now, I'm not sure this is a table of truth, but it's a table with a number of bits of data. And what we've tried to do is combine the different figures that are used in discussion around viral hepatitis so that they sit side by side, which is not often done. And this highlights again how we span lower middle income, upper middle income and high income countries here. And we prioritize the countries here based on the burden of disease from DALYs. And you'll see those numbers on the right-hand column. And I won't go through all of this, but I mean, obviously it's important when we think about elimination to be thinking about the numbers of infections and so forth, but that's not often necessarily the most important thing for policymakers. So just to focus briefly on policy for a moment, one of the recommendations of the Commission that was taken up, and as I said, was led by Jeff Lazarus in particular, with Adam, was this question of whether the most heavily burdened countries have the right policies for elimination, and the development of an elimination index for that. And if we click through here, you hopefully can see a slide which has got the countries coloured. And within that, the green ones are the ones that are on track for hepatitis C elimination. The most developed policies we see are in Brazil, Egypt and USA, and I think we can see that the progress there has been very significant in most measures. But still some very heavily burdened countries, in particular Nigeria and Bangladesh, for example, that when we looked at this didn't have very well developed policies, and many in between that were still developing. And I think Diana will talk a little bit about the Philippines in particular later on. On the next slide, I'll show you what we've tried to look at in terms of the change of this index. So we looked at the index from 2018 and compared it to 2025. So the blue dots are where we were and the red dots are where we are. And you can see where this has shifted to the right. This is a positive move. Bangladesh and Nigeria, I mentioned, have clearly improved their policies over this period. Now, this is obviously a surrogate. What we really care about is overall health. And that's a long way between the policy and that happening. But at least there's some indication of movement. And it gives us a sense that there will be progress to follow, but that needs to be tracked very carefully and not taken for granted. So finally, and I think we may want to revisit this when we come back to the discussion, there were some key themes that emerged from this group. And I'm not claiming this is a representative group of global thought, but I think they are a group who have a broad range of experience. And there were some key themes that did come through discussions about what was emerging. And I think one of these was also in the previous commission, but much more strong message this time around simplification and diagnostics, in this case, particularly for hepatitis B. And I think the hepatitis B guidelines are still complex. And I think Funmi will talk a little bit later about the WHO work on this, which is going to hopefully help, and with some updates due in 2024. But there are still major challenges. And for those less familiar with hepatitis B management, most algorithms involve quite a lot of clinician diagnostic input in decision-making, which is hard to scale up. On the right-hand side, we can think about hepatitis C guidelines, and these have been greatly simplified. And for many countries of high burden, particularly in low-income settings, the simplification and scaling up is the real priority. But in those countries where things are progressing, we're starting to need to look a bit further forward to more individualized models of care, where we're left with a smaller number of people who are struggling to engage with healthcare systems. And I think there are lessons here from diseases like tuberculosis, where we need to be thinking more about short course therapies, about supervised therapies, and so forth. And one of the areas we highlighted in the Commission update was the development of long-acting injectable treatments for hepatitis C, which we would see as being an important step forward in what we could offer some of these groups once that large-scale treatment has been done by and large. And finally, of course, we can't have the sensible conversation we're talking about without talking about financing. You know, we're estimating about 6 billion a year needed to tackle viral hepatitis, and only about a tenth of that is available. And there's a bigger question to have about global funding mechanisms, but as well as increased funding, there's definitely things we can do now to use the funding we've got better. And I think a good example of that is in the procurement of drugs. And there are mechanisms for bringing the costs of drugs down that I think we can share between countries and do much more. It's not straightforward, but it is doable. And I think where it's been done well, it's really transformed what's possible in terms of access to treatment. I won't go through that table again. I think we'll pick up a number of these questions in discussion. But just to finish, to say that, you know, I think viral hepatitis remains a big problem. It's a problem on the scale of HIV and tuberculosis without global resources to do it. We've seen great progress, but it's going to need a continual push and advocacy from everybody interested in this to get anywhere near those 2030 targets at the moment. Thank you.
Thank you very much, Graham, for that fantastic overview of where the Commission has been updated and on our markers of progress towards elimination. I'd now like to invite Professor Diana Purwell to give us an overview of elimination experiences from Asia.
So good evening in the Philippines, and probably good morning to you there. I'd like, of course, to thank, am I audible? Can you hear me? Well, okay, thank you. I'd like, of course, to thank Lancet for this kind invitation, and I hope I can do justice to our experience in Asia. So, how do you move this thing? It's not moving. Oh, here. Okay. Professor Graham has actually elaborated on the 20 countries most heavily burdened with viral hepatitis. And you can see, if you look at it clearly, 65% of it is actually located in the Asia-Pacific region. And more than that, about about 50% of them actually have greater than 5% prevalence of hepatitis B. So when you look at it closely, the priorities for international action was identified in the 2019 Commission. And of course, just to reiterate what Professor Graham has said, it is actually on ensuring diagnostics, access to treatment, monitor progress, testing and models of care, funding, which is exceptionally important in our region, especially that most of the countries that were identified to have more than 5% prevalence of hepatitis B are in the low and middle income. And of course, investment to support countries with greatest burden of viral hepatitis. With this, I'd like to discuss the following. Discuss the landscape of viral hepatitis control in the Asia-Pacific region, try to come up with the gaps, challenges, and probably solutions of whether we are actually in track as far as viral elimination in 2030 is perceived to act. This is the demographics in the 5 countries that I identified to be more than 5% prevalence. And that is China, Indonesia, Myanmar, Vietnam, and the Philippines. Here is that the prevalence is more than 5% and hepatitis B, but hepatitis C is about 1 to 2% and even less than 1% in Asia and in the Philippines. Now, when you look at hepatitis B vaccination at birth and probably in the childhood, which is a very important marker for us to achieve viral elimination by 2030, you can see that Asia, in China, it is more than 96% as a birth dose. And the same with Indonesia, most of them is actually more than 80%. And that is Indonesia, China, Vietnam, and even the Philippines. The Philippines has an 89% received 3 doses of hepatitis B with a study that was published in 2013. Now, only Myanmar has actually a more than 90% as compared to the rest of the countries. When as far as hepatitis B receiving treatment, you can see here that most of the countries have less than 20%. China, which is actually from 11% to 17%, and even if it's less than 20%, you can see there is remarkable improvement in the over 4 or 5 years. There are strategies to improve hepatitis B receiving treatment, such as the simplified service delivery, which is being done in Indonesia. About 34% are eligible for treatment in Vietnam. And in the Philippines, it is quite significant, less than 1%. So that's 38,000, which is newly diagnosed with hepatitis B, but only around 1,200 were given the treatment for hepatitis B therapy annually. For hepatitis C, there is a dramatic increase in China, and there is a free generic DAA therapy in 7 out of 38 countries in Indonesia, seems to be improving in 2022. And in hepatitis C in Myanmar, there is already insufficient evidence both for those receiving treatment and those for hepatitis B and C. And in the Philippines, unfortunately, patients must cover the HCV DAA cost, and the HCV was still priced at $800 for the whole treatment duration, which is quite high for a country which is in the low middle bracket. So with this, we identify now the gaps. What are the gaps that can be seen, and probably address this in the next few years? What is glaring in the 5 countries is that there is insufficient public awareness, seen both in China, Indonesia, Myanmar, the Vietnam, and the Philippines. And of course, Myanmar hypes over the COVID-19 pandemic and the political unrest. Stigma is quite predominant in China, in my country, and that is why there seems to be now a strategy to address the stigma through increasing public awareness. What are then the steps that were done to address these problems? There is a national centralized drug procurement, reduction of cost of hepatitis B in China. There is both an implementation of the HCV and HBV surveillance in Indonesia, in Myanmar, and even in the Philippines. And of course, even if you have the technology to actually have online surveillance, there are technical shortcomings that becomes predominantly seen in Vietnam. And this then produced already a deceleration or a problem as far as achieving eradication in 2030. National Action Plan was actually one of the key factors. And it was actually done both in China, Indonesia, actually 4 out of the 5 countries. We are doing a new action plan right now in the Philippines. And even if there is a national action plan all the way back in 2017, is this the answer? Because out of the 5 countries that were identified, 4 of them have a national action plan of more than 2 to 3 years, and yet the prevalence rate is not seen to be decreasing and is still over 5%. So the gaps that I feel that should be addressed is, number 1 is simplicity. We need, if we will draw the care of hepatitis B to primary care physicians, then simplification of management guidelines should be a priority. The point of care test should allow greater access to viral detection. The The country is an archipelago. My country is an archipelago, which is actually distributed in 7,000 islands, separated by bodies of water. And therefore, point of care, meaning one patient should only go to a physician once. But with the strategy of the guidelines right now, a patient has to go back 3 to 5 times before being treated. And that's quite a burden to a low middle income country. Finances, no specific international funding for viral hepatitis. And as I mentioned, the LMIC, or low middle income countries, have been expected to take much of the financial burden. And lastly, of course, which is very important, geopolitics, the COVID-19 pandemic, and the geographical logistics. As mentioned, geopolitics play an important role, especially in Myanmar, which has a lot of problems right now as far as politics is concerned. And this probably is one of the reasons why they cannot come up with a better strategy to implement the policies that are there already. So when you look at the policy index, you can see here that most of the countries have actually improved, except, of course, in my country, in the Philippines. As I mentioned, COVID-19 plays a significant role as far as this is concerned, and my country has a change of hats. We have a new president in the last 2 years ago, and this, of course, has to have new people in the Department of Health, which probably is one reason why policies are not yet, policies are there, but not properly implemented. So let us meet the Philippines. We are now addressing HBV gap. On the right side of your screen, you can see when we hosted the Asia Pacific Study of the Liver, 4 big hepatology organization, the Asia Pacific Study of the Liver, the EASL, the AA, and of course the ALE, all joined hands to implement the no discrimination for patients with viral hepatitis. So I think this is where we now draw how hepatology societies can help us as far as this is concerned. Renewing the vaccine drive. Now there are community-based centers of regular drug dispensing and supervised treatment to implement existing elimination program. And if this is done, you can see on the right side of the screen that more than 90% are actually achieved treatment for hepatitis C in community-based center. As I mentioned, because we are an archipelago of 7,641 islands, we need to have an expanding access. It cannot be only a centralized access. We need to decentralize. We need to make use of healthcare workers, aside from doctors and primary care physicians, to treat patients for hepatitis C, B, and C. Now, this was a framework that we've done in 2030, and I uphold the Department of Health for doing this way back in 2017. The preparation, the demonstration, the execution, and of course, sustainability. And below that are the different guidelines that were done. However, as I mentioned, because of COVID-19, this has actually taken a halt. You can see here, the Vaccination Act was there. It was way back, wherein the Act provides mandatory basic immunization for infants. But in 2018, we were marred by a dengue vaccine, a scare for people who were given the dengue vaccine. And this produced a hesitancy for most of the Filipinos to undergo vaccination. And of course, in 2020, we have the COVID-19, wherein more of the policies, more of the access and finances were geared toward vaccination for the population for COVID-19. This then produced a dip in the vaccination program of patients for hepatitis B. We have declared 2 laws, the Republic Act of both, to implement a awareness for liver cancer and also for hepatitis B. So this is in 2017, as I mentioned, we hype over the 4 great policy in preventing and controlling viral hepatitis. And this is going over the HIV, AIDS, and STI prevention and control program. The advocacy and awareness, the robust research, of course, there is already, as I mentioned, the World Hepatitis Day, which is officially declared every July 28th. And the Health Promotion Bureau, which hypes over this. But as I mentioned, because of the change of hats, there seems to be now new people that we need to deal with. There is a new guideline that we've done during pandemic, and this is the hepatitis B that is being rolled out right now, which actually cuts the coming in of patients and doctors' visit. There is a scale up of access to hepatitis B dose. This is now advocated by our insurance system. And of course, access to effective hepatitis treatment and monitoring and evaluation, and of course, to target outcomes. This is one strategy that we've done. I congratulate the Hepatology Society of the Philippines as it partners with the Philippine College of Physicians to promote primary care physicians to actually have a module for them to be able to ask questions or educate themselves on how to treat patients for hepatitis B. And of course, this is the hub that I was telling. There was a hepatitis B. This was done in 2017, 2018, and 2019, wherein there were 27 sites that were identified to have a model for hepatitis B screening and treatment, of which the 3 sites were identified to referral centers. It seems to be a strategy that would work when you put hubs in different islands, and probably then you can put a system for this archipelago to actually move towards the eradication. So here you can see here that this was done, but this was in 2019. The same with the hepatitis C. You can see that most of these patients, I showed you, almost 90% of these patients were actually treated because of this strategy. So lastly, the problems were identified as for hepatitis B. The birth dose is not implemented in the real world, but actually in the 3 to 5, we achieve about 89%. There is limited access to antiviral drugs. Although there are hubs, some of these drugs were not available at the time. And because you know for a fact that during the COVID, there was a problem in transport of the drugs, this was the main problem. High rate of undetected cases, the lack or complicated care structures. As I mentioned, 3 to 5 visits for us to be able to treat patients, and now we are cutting down with a new guideline. There is no curative treatment as far as hepatitis B is concerned, and therefore we need to put these patients on prolonged treatment, and that is where the problem is it's going to be supported by the government. For hepatitis C, there's limited access to antivirals. There is a high rate of new infections and reinfections, and this is being addressed right now. Lack of or complicated care structures from the diagnosis to therapy, and of course, the therapy of acute HCVs is not. So when you look at it, what we'd like to do in the Asia-Pacific region is let us close the circle together. And this is what we cry, a renewed action. Although most of the countries with more than 5% prevalence have a national action plan, I think it has to have more teeth. There should be a legislation, there should be a law. Because in tuberculosis in the Philippines and HIV, there is a law. And that is why there is more control measures that can actually be instigated, and people will obey. Research, as mentioned by Professor Graham, on long-acting formulations safe for pregnant women, and of course for IV injections. This is something that we'd like to look forward to. For urgent solution, an international funding body to help us in viral hepatitis and access to drug. Simplification of guidelines, we've done it, and we will await the 2024 guideline of the WHO. Collaboration of multiple stakeholders. We will hold the Asia-Pacific Study of the Liver in the next few weeks, and probably we will also, in the Apostle, which is the Asia, wherein we can probably come up with new strategies in the Asia-Pacific region. Access to drugs, this is something that needs to be addressed, although now we have seen a dramatic decrease in the drugs, cheaper drugs, because they have gone down by more than 50%. Of course, address unmet needs like awareness. We've done this to strengthen policies. There are policies, but it is the implementation of these policies that is important. So lastly, I ask a question. Are we on track? And I think we are, slowly but surely. With this, I'd like to thank, of course, the Commission for inviting And I know in the Asia Pacific region, we will do our share. Thank you for your time.
Thank you very much, Diana, for some wonderful insights into how we're making progress in the Asia Pacific region. Please do keep your questions coming in the Q&A section of the webinar platform, and we will get to those, as many of those as we can, at the end of the presentations. I would now like to introduce Professor Haley Michael Dessalines to talk about the situation in terms of viral hepatitis elimination in sub-Saharan Africa. Over to you, Haley.
Thanks so much, Rob, for the kind introduction, and thank you, the Lancet, for giving this opportunity to present on the viral hepatitis elimination plans. And thank you, Dr. Graham Cook, for such excellent publications. So I will walk us through some introductory parts and then progress in the country response and what practically we have faced the challenges in hepatitis care and the way forward in the viral hepatitis elimination. So this has been discussed well. So these have been the changes in the hepatitis policy index score. These are the top 20 most heavily burdened countries as we have seen. And I would like to note also again that they also comprise 75% of the global burden of viral hepatitis. So when we target elimination, these are the major areas, these are the major countries that should be focused for 2030 elimination. So when we see countries in Africa, Egypt has recently won the gold tier for hepatitis elimination, mainly by the work of the hepatitis C, but still there are some work that should be done also on hepatitis B prevalence and treatment. The other countries, it's Ethiopia from the African countries, who looks stagnant, who hasn't done any change from here that you see from 2018 to 2023, and countries like Democratic Republic Congo. These two countries are in the low income setting and having a difficulty in reaching the elimination, even though we'll see what progress has been done in this country. When these both countries actually have their own national plan and strategic agenda, but there is a need to push forward due to the different barriers and overstretched health care, and also some unrest in the different parties that could limit the care of the vaccine and the treatment. In Nigeria, you have seen a progress, but still it's also one of the low middle income countries with a higher population in Africa, with higher daily in viral hepatitis care. So the policy progress, like as has been mentioned in Ukraine and Myanmar, also Ethiopia, had been static and slow. It's also not only their policy, but sometimes there are like political unrests and the COVID-19 pandemic, which happened between this 2018 and 2023 during this year, that could disrupt the hepatitis B care. It also affects, for example, the birth dose implementation plan, which had been started in Ethiopia as a pilot to start at different regions, but it was disrupted due to some unrests that could happen, which are unprecedented. Sub-Saharan Africa is like having a 1.18 billion people. The two most populous countries in Sub-Saharan Africa are Nigeria and then followed by Ethiopia. When you see the health expenditure is also the lowest, and they don't have partner support. And we can see 2/3 of the new hepatitis B virus infections globally occur in Africa. So Nigeria, Ethiopia, and Egypt and the DRC had been one of the top 20 countries most heavily burdened, and this is based on the disability adjusted life years. If you just see the prevalence of the hepatitis B and C in these countries, Nigeria having 11% prevalence of Hep B and hepatitis C around 1%, and Ethiopia 9.4% of hepatitis B virus prevalence and 2% hepatitis C prevalence, will have a daily of around 502 and 806,000. So this cascade of care defines actually most of the African countries. And also when you see the cascade of care for Hep B and C in Africa and Ethiopia, it looks like this. With the majority infected individuals, you can see 7.8 million individuals being infected. And those diagnosed are around less than 10%. You can say treatment eligible who are diagnosed are less than 1%. So this cascade of care is important for us to design policies, how to reach those individuals who need to be diagnosed and those also who need to be treated. When you see the graph of other countries also from the this Center for Disease Analysis, it looks the same for other diseases, like for the hepatitis C and also for the other African countries. Hep B-related diseases had been an increased exponential. This from the Coalition for Global Hepatitis Elimination. There are some surges that you see around 2016, but it's also increasing above the WHO target. When you see the mortality of Hep B-related diseases, and also the mortality of Hep C-related disease is very high. One challenge that you get from such modeling studies is, unless you have a good data, it's difficult actually to do modeling. And most of these data, when there is no surveillance study, it depends on low quality of data evidences from expert opinion. So that could affect also the results, but this is the best data that we have to estimate the mortality of Hep B related diseases and hepatitis C related diseases. The different milestones, if I start from the Ethiopian, after the 2014, the World Hepatitis Alliance, 2015, in Ethiopia, we have this national viral hepatitis guideline has been produced. And with the support of the collaborators, we started a pilot hepatitis B treatment and care at one of the major centers in Ethiopia. We started progressively. We include at least 1,300 patients in care, which now it's almost 8 years since these individuals had been in care and follow-up. The National Technical Working Group has strengthened the 2016 at the national level, and distribution of policy documents has been done. 2017 was also a big change. The National Prevalence Study on Hepatitis B virus. This is actually not a survey, but based on the available data. This is how you can use available resources. So based on the NCD samples or blood stored, the national prevalence of Hep B was estimated because that sample had at least 10,000 individuals from each regions equally represented. That's how we got 9.4 prevalence from this study in 2017. Health worker vaccination, world hepatitis activities had also been started, and treatment scale-up has also been increased at the national level here. In 2019 was a change that probably has improved somehow in the policy index because it has been now integrated with the HIV program, and also procurement of drugs and reagents based on the capacity has been started. 2021, 2015, we have our team has also started scale up of hepatitis B projects, and guideline revision and also national strategic plan has been also revised. And coalition has also helped us to build the national hepatitis elimination profile for Ethiopia. And we are also doing the economic analysis of hepatitis B and C elimination in the country. So we have the government support, like building these strategic plans and the guidelines and distribution of national training guidelines, and also implementation of several pilot studies to increase Hep B vaccination treatment. Considering these pilot programs of hepatitis B, it had been done at least for 1 year, and efficacy and operational feasibility study has been done, but it could not be further disseminated due to the lack of budget. And actually, as has been said, we're waiting for the Gavi, but all the studies of this pilot program and feasibility shows that it is positive and to implement the hepatitis B first dose across the countries. Considering countries like Nigeria, there are also a big change with the support of the civil society organization and the African Hepatitis Summit. So the involvement of the civil service organizations is an important step that could help countries to push the political will. But there are many barriers, like Ethiopia or others. We see lack of epidemiological data and lack of funding. It is a general fact, and high out-of-pocket costs of testing and treatment in these low and low to middle-income countries, and guidelines that rely on sophisticated and expensive tests. This is also one important barrier for low-income setting. If you see, based on the WHO tier, low healthcare facilities will not have the intended or the requested laboratories or capacity to start treatment if they rely on the guidelines by the international societies. So our program have a scale-up of hepatitis B program. So we use a simplified integrated program and to decentralize into 4 regional hospitals and to enroll at least 6,000 patients, and utilization of point-of-care tests with rapid around time, and with data from the Ethiopian study and the HepSanet, which is Hepatitis in Africa Network, and to develop a new simplified treatment algorithm. So this is one part of the programs that we also use at the national level, in addition to the national program by the Ministry of Health. So the HepSanet, the Hepatitis in Africa Network, has been published. It helps us to at least have a better non-invasive test cutoff to use for African, and we use that cutoff to which has a higher sensitivity to detect individuals with early fibrosis or early cirrhosis, and to start them on treatment. And these have been said at elimination pillars, but I just want to be like specific to the Africans. So we need actually global fund is very important to push, and I just want to show political will and prioritization based on the studies of cost-effectiveness study. Cost-effectiveness studies by Shivanti have shown that early treatment is also cost beneficial if you investment. So these are some of the studies. And Gavi support and prevention. Sometimes we see that there is a need of data from Africans, but different studies have shown that a bird's dose is quite effective, and we are also doing with the support from the Imperial College on the effectiveness of the bird's dose vaccine programs. And on the investigation part, I would like to say we need to go down into the DBS testing, and the point of care test should be done at the lower tier level, lower tier like 0 and 1. And then reflex testing is one important that comes from Hep C that could probably help also decrease the follow-up time of individuals. Like we don't need to call them back for viral DNA or other tests, or that can also be for Delta, and minimize monitoring of individuals who are less likely to progress. So we need to have research that individuals that needs 1 year of follow-up can come use 1 year rather than stringent follow-up protocols, decreasing also the use of viral load, and then this will lead us to decentralization programs. And I'd like to thank also for the monitoring, the national hepatitis elimination profiles, and the policy index from the CDC could help us also like monitoring once it has been done, and then Ethiopia has been here at this level, and then after a while, monitoring from the previously published country profiles from big organizations like the Coalition for Global Hepatitis Elimination could help also push the countries. And finally, this is probably my last slide. I just want to show this a schematic drawing showing the center. You see there is a hub. Usually I have in this project Eco Clinic. The hub can be a big treatment center that we started with from one hub. Usually we start from one. That hub can also help us for a training of the different centers. And the hub in Spoke, like the other different centers, can have peer-to-peer learning, or it could help us also for diagnostics, like the referral of DBS samples to the major centers can be used with the center. We started from one, and we increased to at least 4 hospitals now in our program, in our project, but this can also be done at a national level to increase more hospitals, but it should be decentralized to health center or to the county levels. And based on the available resources, these county levels should treat patients with hepatitis B rather than waiting for the sophisticated recommendations from the guidelines. So integration, simplification, task sharing, and centralization is one thing that we recommend. So finally, I would like to say simplified treatment criteria based on available resources is what we recommend. Decentralization of care and task sharing is important. So otherwise, we'll expect more than 10 million people with HEPI to be treated with few centers in low-income setting is practical. Improvement in screening strategy and linkage to care. This is also important. We may have a treatment program, but if there is no active screening and patients are asymptomatic and undiagnosed, so that's also a big problem in the African low-income settings. So improvement screening is what we recommend. And then innovative financing strategies and prioritization that comes with political will. And then African guideline or guidelines based on the country's context is also important based on the availability of the resources. Finally, I would like to acknowledge the whole groups here and also the HepSanit, a big support from HepSanit and Asker Hansen from the Westfold Hospital. And thank you so much.
Thank you ever so much, Haley. There's some very interesting points on decentralization of care that we'll hopefully touch on in the questions and answers session. So next, I would like to move to a more global perspective on progress towards hepatitis elimination from Funmi Lesi from the WHO. Over to you, Funmi. Thank you for joining us.
Thank you very much, Rob, and many thanks to the Lancet group for inviting me to participate in the launch webinar. And like you said, I would provide this global perspective. And Professor Graham had talked about the important cause of liver disease and cancer of hepatitis. And just to mention that it does not only devastate individual lives and communities, it has a negative impact on social well-being and economic progression and posterity. So our shared vision for elimination has the potential of saving over 2.8 million lives before 2030 and averting multiple new infections and cancer. Okay, and the next slide. So WHO, on whose behalf I talk right now, congratulates the Lancet Commission on the publication and welcomes the second edition of this commission. Now, the identification of the 20 countries based on DALIs as well as the narrative evaluation in this report speaks to the need to prioritize and tailor solutions to both the global and the local context. So my brief outline will be to make two important points on the global achievements, the progress, the gaps of the first global health sector strategy, and then maybe talk briefly about the key shifts that are required to accelerate progress towards elimination, and then some take-home messages. So the first global strategy was published in 2016, that's about 8 years ago, and specifically called for a paradigm shift from specialist care to a public health approach, putting countries at the center of the response. Now, this slide summarizes the achievements and the gaps as published in the WHO Global Progress Report of 2021. Now, just to note that the updated reports for 2024 will be launched in the second quarter of this year. Now, by far one of the most significant achievements in that period was the achievement of the 2030 target for hepatitis B incidence, which is the prevalence of hepatitis B surface antigen equals to or less than 1% in children under the age of 5. Now, this was observed in all of the regions except in one region. So obviously the introduction and the scale up of hepatitis B childhood and birth dose vaccination were foundational to this success. Now, the high number of new infections and deaths were also recorded in 2029. On the right panel, we see the major gaps in the cascade of care elaborated and the scale of the response, as well as regional disparity, as has been highlighted by the previous speakers. So we come now to the global, in 2021, at the end of the first global strategy, the new strategy was developed to bridge the gap towards elimination. And it was shaped by emerging evidence and lessons learned from the COVID-19 pandemic, with the goal of guiding the health sector in implementing specific actions towards ending these epidemics and achieving the goals. It maintains the public health approach and elaborates 5 strategic directions and actions for countries to take. So look at some of the key shifts that are required to end the epidemic. And previous speakers have really alluded to the importance of public awareness, financial resources, and other things on the slide. So the impact to reach elimination, to end viral hepatitis epidemic is shown on the right with a red star. Now, to reach this desired impact, the main outputs and outcomes that drive progress and results are shown in the middle panel. And I want to highlight a few things. The first 2 bullets here are development of global guidance as well as national policies and plans. As we have heard today, many countries have developed these policies and plans, and many have also adopted WHO guidelines, which are kind of comprehensive across both hepatitis B and C. So if we imagine a color-coded like scorecard, these aspects of policy development will not be red, perhaps not green, which means go, good, great progress, but definitely yellow, which signifies some progress made. Now, the last 3 or 4 relate to service delivery, the need to strengthen health systems and engage communities, and the scorecard will definitely read like red. So perhaps a shift, not just to policy, but to practice and implementation, service delivery, expanding access are critical to progress. The last part of this is the input. Now, the panel on the far left articulates the inputs in this results framework that are needed to drive the response, and it is clear that all of these 7 inputs on the right are in the red. So progress has been slow, especially in political awareness and in funding. So on my next slide, I asked the question, so how do we measure success? We talk about progress. How do we track progress to elimination? What are the standardized tools and the metrics to measure progress? Now, in 2021, WHO, in collaboration with global experts and partners, elaborated this framework to validate achievement of elimination using both the impact targets and the program targets. And of course, we know that the program targets are based on the 5 core interventions, which has been highlighted today, including hepatitis B, PMTCT, childhood vaccination, harm reduction, as well as testing and treatment, which we all know so well. Now, on this slide, the panel on the right displays what we call the absolute impact targets for HBV incidence, HCV incidence, and mortality. Now, these absolute targets, they align with the goal of elimination and the relative targets of 90% reduction in incidence and the 65% reduction in mortality using the 2015 as a baseline year. The panel on the right addresses the program targets across key interventions for viral hepatitis and shows the targets for 2020, 2025, and 2030. So we have declared and defined that elimination requires demonstration of meeting both the absolute impact and the program coverage targets. And these represent the standardized measuring tools across different epidemiologies, contexts, and different countries. Now, in 2021-2022, I led our global hepatitis team on a series of country pilots to assess the feasibility of elimination criteria in terms of the impact and program targets that has been discussed. And the key findings are shown on the slides, and they're quite interesting. Now, achieving program targets was clearly feasible in all countries, apart from a few challenges related with standardization of measurements and programs, notably the injection safety in healthcare and in the community, as well as needle syringe programs for people who inject drugs. Now, achieving and measuring absolute incidence or mortality was a different challenge, and it was faced by all pilot countries. So there are some key takeaways, some key lessons, the need for countries to strengthen surveillance and data, and the request from countries for what we call a path to elimination. And very briefly, our findings contributed to the development of this model called path to elimination. And this is shown here. It's a 3-tier system with a stepwise progression of attaining global program targets to facilitate elimination. The progression is captured using Olympic tiers that are well recognized by all: bronze, silver, gold. And just to note that the 2025 targets are the benchmark for the bronze tier. So an example in terms of testing is target of 60%, 70%, 80% diagnosed for bronze, silver, gold, respectively, where the ultimate goal is for 90% testing. So path to elimination shifts the paradigm to an operational focus on program development and programming with innovations in service delivery without the immediate requirement to demonstrate attainment of absolute incidence and mortality. And like Dr. Haile Michael said, Egypt was awarded the gold tier for PTE in late 2023. So what will it take to get on the path to elimination? These have been mentioned by all the speakers, and just highlighting a few areas. Leadership. One of the elephant in the room really is funding. And on this slide, there are highlights for how funding allocation should be managed from the national budget, from donor funding, from managing the cost of commodities. And of course, we must not forget public-private partnerships. Service delivery is very important. Data, systems, and stakeholder engagements are key. I will not unpack all of these inputs in this very short presentation. And this is one of my favorite pictures showing the president of Egypt receiving the certification from the WHO Director General. So what is new? What is coming? In terms of taking action, 2022, 2023 saw the development of criteria for validation, path to elimination. The HCD guidelines were updated with expansion of treatment to adolescents and children. Haile Michael mentioned the simplified service delivery as well as Diana, and we're looking at decentralization, integration, task shifting, all of which are central to a differentiated service delivery. So for the year 2024, we have 3 exciting products that will be launched in the next couple of weeks. And the first of these will be the hepatitis B guidelines, which we have all been waiting for. And we hope that these guidelines will facilitate the transformation of the hepatitis B response to a public health approach. The updates are in several domains as shown on the screen, but I would not go into details. But we need to look at the assessment, the treatment eligibility and regimens. PMTCT is very important, and diagnostics, including practice principles for hepatitis B service delivery. The second is really the Consolidated Strategic Information Guidance, which has been updated. And this new report will be launched at World Hepatitis Summit and has new data on EPI and monitoring and evaluation for nearly over 180 countries. And that is very exciting. And we're looking to the launch of this document. And the access report, which has the global epidemiology, and will also unpack several dimensions of access to viral hepatitis products from a public health perspective, as well as make recommendations for decision makers to make effective use of these opportunities. And I'll stop right here and just to highlight the 3 take-home messages: that the gaps for elimination are real, and closing this gap has the potential to save millions of lives and prevent deaths, and working with the guidelines and the guidance we have, strengthen the health systems. Now, reaching elimination requires key shifts. These shifts are strategic shifts, looking at the global health sector strategy. They are operational shifts that are covered in program management, and it definitely involves innovation. And lastly, collaboration and partnership cannot be undermined. They really are the focus for foundations and launching of programs in many countries in collaboration with governments and local partners and international partners. And on that note, I'm going to say a huge thank you and acknowledge my colleagues from the Global Hepatitis Program and the various multiple partners which are not listed on this stand. So thank you very much, Rob. Over to you. I'm looking forward to some exciting questions and discussion. Thank you, and over.
Thank you very much, Funmi, and we're certainly all waiting very eagerly for the new WHO hepatitis B guidelines. We're looking very much forward to those. So now we will move on to a question and answer session. I'll address some of the questions that have come up during the presentations, and we're now joined also by Lindsay Hebert from the Coalition for Global Hepatitis Elimination 2. So Graham, I thought we'd perhaps kick off with one of the themes that you brought out early on in your presentation was the inconsistency of the epidemiological data across countries. How urgently does this need to be addressed, and how can it perhaps be improved?
Yeah, it's an interesting question. I think Funmi may want to come in on this as well. I think we have to decide what we're trying to influence with the data and what we're going to use it for first, I think, and then which of the data sets that we have available is going to be the most appropriate, and to what extent that needs to be as precise as it could be to make the best decisions. And I suppose clearly the most accurate, the more accurate the data is, the better. But there is a cost to that, and there is an effort to that could be spent in other ways, and that's the balance. And I guess if I had an example from the Commission, then when we first published, then we had the countries identified, and I think I understood secondhand that if anyone can comment, please come in. But that the Bangladesh Ministry of Health saw the burden of disease attributed to Bangladesh and felt they wanted to reach out to WHO, get more advice, and start a process of trying to improve the services. And I suppose in that setting, it's important to have that data and important to sort of see where the burden of disease sits, but the precise value of the burden of disease in that setting is less important than the fact that it's just high. And then I guess the other side of it is that as we move to a more national focus, really what we've got to do is to get much more granular data. And I think anyone involved in national programs understand that in terms of that planning, you want to get much more granular and have, you don't want to have model data, you want to have measured data, and you want to be able to look at different regions and so forth. And I think there is a piece of work that has been done in some countries, but not others, just systematically going through that and really understanding where the different burden of disease is, what risk groups are affected, and so forth, and really trying to use that to plan local regional services depending on the unit of delivery for the health system where you are. So that's a sort of long answer, but I think clearly it's important. But I think that we need to recognise that we don't have to get it precise to necessarily make the right decisions.
Sure, thank you. Funmi, could you provide some insight into the data activities that WHO's Global Hepatitis Reporting System provides?
Yeah, thank you. I think it's a fantastic question, and truly there is really a dearth of data in viral hepatitis in many countries. And just to quickly highlight what this global reporting system for hepatitis has been developed by WHO in 2015. And it was initially developed as a web-based district health information module, DataS2, which was localized on the WHO integrated data. And in the first few years of operation, about 42 countries reported. It has standardized indicators for programming, for surveys as required, and for the pertinent policies of viral hepatitis elimination. The first few years, 42 countries reported, but as of January 2028, about 68 countries were reporting. Now, this system has since evolved, and the reporting was to be from the Ministry of Health directly to the WHO offices and regional offices to the global team. Trainings and capacity building had gone on, but now there has been a bit of an evolution of this process and this reporting system. It's more collaborative now, and we have data partners, data collaboratives. We have better refined, standardized global indicators. And if you remember in the pilot, we had challenges with interpreting indicators. So this is much, much more improved. In the last report, we had 130 countries reporting. And in the upcoming report that will be in the second quarter of this year, we have over 180 countries reporting on standardized indicators. So taking hepatitis up to a national level and standardizing data across regions and countries is what we are trying to do for data consistency, and collaboration and partnerships in this area are also key. Maybe I'll stop here now because I'm sure some people have additional to add to it. Thank you.
Thank you very much. That's great to hear that the data is becoming more and more complete over time. So, Lindsay, what role does the coalition play in helping to build and disseminate the evidence base? You haven't had time to introduce your work, so now I think there's a good opportunity to help explain what your role is.
Thanks so much, Rob, and thanks to Lancet Gastro Hep and all the panelists. It's a real honor to join you today, and really excited to celebrate this publication and all the wonderful work happening in hepatitis elimination. For those of you who the coalition is new, we were launched in 2019 to help countries accelerate progress towards elimination. We work by building a community of practice, by strengthening the evidence base, producing tools, resources, operational research, and then lastly, by mobilizing commitment at the local, national, all the way up to the UN level. The initiative to develop national hepatitis elimination profiles, we refer to them as NHEPs in short, was really about helping tell the full story of hepatitis elimination and bringing together those data sources that Fumi mentioned and were presented by our panelists with the policy information of what countries are putting in place to sustain a program over time in terms of testing policies, treatment policies, equity information, and bring out the recent achievements, the key challenges, the innovations, what country leaders feel are the next steps, and have that in one place as an advocacy tool. We really see our role as helping amplify and disseminate the data available, make it more accessible to government partners and CSOs and researchers, and help bring everyone together about what needs to be done.
Thank you very much, Lindsay. So I'm going to jump to some of the questions that have come in the Q&A session, and actually one from John Ward, who's director of the coalition, very rightly highlights. We focus a lot on the mortality morbidity data, but as Funmi alluded to, there's also the programmatic aspects of elimination to target. And John's sort of asking whether we have any good data on prevention of new infections, particularly of hepatitis B, in terms of the status of safe injections in healthcare and in the communities, and also what the status of adult Hep B vaccination is. I don't know who wants to take that first. I think the question perhaps came in initially with for Diana in the Asia Pacific region. What is the status of safe injection practices?
Oh, okay, thank you. I will speak for my country. So we do have a safe injection on as far as the law is concerned. But as I mentioned, our last president, President Duterte, actually has a very strong policy for illegal drugs. And this actually helped us in controlling, indirectly helping us in controlling our drug-related issues. Now, as far as adult vaccination, I think he was also asking about adult vaccination for hepatitis B. as present, we still recommend only those with 19 to 59 years old or elders who have the risk for hepatitis B infection. So we're not doing the across the board hepatitis B injection for adults. So I think that's one thing. And as well, my problem here, or the caveat here, is that for patients who are elder, we do not recommend for immunotolerant phase. These are patients with very high HBV DNA, and yet the liver enzymes are normal, or maybe do not have fibrosis. The recommendation right now is not to treat, and yet they are actually there spreading the virus. So this is where strategy of issues of treat all patients with hepatitis B with drugs, because the drugs right now are, as mentioned, a little cheaper, and there is less resistance. So I guess this is where we need to focus on whether we will advocate this strategy of treat all, which is what we did in COVID. So I guess this I'd like to ask our panel. Also, I'd like to ask the coalition, Professor Lindsay, how do you address your presence in small countries? I want to know whether we need to be a member of the coalition to make it active as far as getting all the programs in place. Do you reach out to the 20 burden countries, small countries like the Philippines, Myanmar, and Vietnam? Are you actively present in these small or low middle income countries?
Rob, would you like me to take that now? Or
yes, please, yes.
Sure. Thanks, Diana, for that question. And the short answer is everyone's invited to work with the coalition. It really is a broad network. All hands are needed to achieve hepatitis elimination. And obviously, the highest burden countries are driving global progress. But every person living with hepatitis is equal and deserves access to testing and treatment. So it's important to ensure good policies are in development in all countries globally. And so we're certainly here to work with any country that is committed to hepatitis elimination. And for the countries you mentioned, we've developed profiles to date for a few of them, Philippines, Indonesia, Myanmar, in the Southeast Asia region, but we're very happy to add more countries. These profiles must stay updated and dynamic to be useful to countries, and so we need to revisit them and continue to improve them as we go along. And so I hope that's an invitation to continue to work together and see how we can have better partnerships and more work in the countries mentioned.
Thank you, Lindsay. Now, Hayley Michael, you mentioned the HepSanet collaboration during your talk, and mentioned that the development of a simplified HPV treatment algorithm, which we published last night alongside the Commission. And I think this is kind of part of the question about decentralization of hepatitis B care. Could you give us a brief overview of the new treatment guidelines and what it would actually mean? Sorry, the treatment algorithm and what it might mean for care in sub-Saharan Africa.
Thanks so much, Dr. Rob. And I would like to congratulate the HepSanet team for such excellent work. So the HepSanet it's a hepatitis network that was established after COLA 2020 meeting. So as we have been saying that there's a big data problem in Africa also to base guidelines. So it tries to merge available data that have been collected in Africa. And through time, we have involved 8 countries and up to 8 countries with 11 centers. Actually, in this study, 13 centers has been included. So just to mention the most important thing here is in the decentralized program, it was a nice work by the HepSanet team. We initially do the survey to assess the availability of those clinicians that can diagnose decompensation, or that can at least use the guideline that we use as a gold standard. and also assess the availability of the laboratory tests. What are the available laboratory tests in each centers? So based on that and using the tier of the WHO system from 0 to 4, I just mean like 0 tier could be small centers or mobile clinics up to a higher centers. So this HepSanit score has come that could help to decentralize at a district hospital level. It's basically using the ALT, the AST, and platelets, which based on the first survey that the physicians or the working in those centers have said that it is available. So the HepSanit score uses the guidelines. The EASL has been used as gold standard, but WHO and APRI has also been used. And then it assesses what the sensitivity of using these tests, based on the availability of the tests, it comes out into a score. So it has ALT, AST, and platelet, which majority of the centers have. And based on that, a score of 2 has come from these scores based on using some analysis, and that has a better sensitivity and specificity of at least 80% sensitivity and more than 87% specificity to diagnose of or to treat patients based on the hepatitis B. So simplified down to the district hospital level and based on the available resources and based on the available manpower. So this could help to decentralize the treatment program in the African setup. I think I would like to congratulate the HepSanit team and thank you for Lancet for this excellent news.
Thank you. It's a very helpful tool, hopefully, to really simplify access to treatment. There are a couple of the questions that have come in are related to the impact of COVID and what we can take away from lessons that we learnt during the pandemic. How can we transfer that knowledge to hepatitis elimination? Graham, do you want to take that one first?
Yeah, I mean, I think I touched on some of that, didn't I, earlier on? And I mean, there are a number of aspects, but I think the decentralization issue is critical. And there were lots of examples of where decentralization was used in healthcare systems that I think can be built on. And we might want to, I'd be interested to ask Harley Michael about the realities of that in a setting where there aren't very many healthcare workers, because there is a need for that. But telemedicine can overcome some of that difficulty, and so some of those innovations could be helpful. And I do think this move towards acceptance and understanding of self-testing is quite important. And, all of us, I imagine, have been putting things up our nose that we wouldn't have been putting up our nose a few years ago. And it's easy to underestimate how many barriers there were to doing that prior to the pandemic, both particularly from a regulatory point of view and a sort of from a health system point of view. And moving to a situation where we're more comfortable with people taking their own samples and perhaps being able to do things remotely, I think is quite helpful. And that can be helpful in some aspects of care when you're trying to do things at distance. And the technology needs to catch up a bit, I think, for viral hepatitis, but certainly for some of the testing, that can be something that helps scale up the testing. And it's really the testing, as everyone's touched on, which is the main challenge now. Right? So, we really have to focus on getting the numbers of people diagnosed up. And if we can do that, then, that will help us substantially. But just dealing with the people in front of us is not going to be enough. So I think there are a number of others too, but I think those are two things that come to mind in terms of really what could be built upon in terms of the post-COVID legacy.
Thank you very much, Graham. I think we've already got time for one more query. I wondered whether Funmi, you could, some of the questions that have been coming in are sort of relate to what we can learn from responses to other major infectious diseases such as HIV and TB. And I know the viral hepatitis team is embedded within a broader group at WHO, and I wondered whether you could shed some light onto the lessons we can learn from responses to those other major infectious diseases. I think you're on mute.
To learn.
Oh, there you go.
Okay, can you hear me now?
Yes.
Yes, so I think there are lots of lessons to learn. I'm going to mention first the obvious. In terms of community engagement, for me, that was a personal and global revelation that except you carry the people along, public health diseases will have a challenge. And in COVID, it was clear that except we sensitize communities, wearing face masks and everything, it will not work. So the community engagement for viral hepatitis needs to expand, that we must involve the community, I'm talking like an activist, in planning and implementation. The second thing is integrated diagnostic platforms. You know, we call them the multiplex platforms, the platforms that can do multiple different testing. I think this is very important and one of the key lessons learned. In terms of HIV, there's so much to learn in HIV because it's so similar to hepatitis B in some aspects in terms of long-term care. And one of the weakest links in hepatitis B is adherence. And there's so much to learn from long-term care and adherence in HIV for hepatitis B. I think I'll stop there because I'm sure that everybody has some contributions. But COVID-19 opened a real Pandora's box of good options and opportunities, and of course, challenges and threats. Thank you, and over.
Thank you very much, Femi. I think, unfortunately, that is about all the time we have today. Thank you very much to all of our panelists and presenters for joining us this afternoon. Thank you. And thank you also for the audience for joining and participating with your questions and answers. In wrapping up, I strongly urge you to look at the Commission and the other content that is linked with it, including a comment from the World Hepatitis Alliance and the importance of civil society and engaging in viral hepatitis elimination efforts, amongst many other great pieces. So please do take your time to look at those and give them a read over. Thank you very much. We will be sending out a link of questions and of a survey in due course, so please do take a moment to fill that in to help us improve our future offerings. Thank you very much.